Hi, this is QD Clinic. I'm Jack Cush with Room Now. QD Clinic is brought to you by RoomNow.live. The meeting's a week away, the best meeting of the year. Hope you'll be there. Today's case is combination biologics, legit or not. So the patient is a 55-year-old male who's had long-standing psoriasis, pretty severe, and really severe psoriatic arthritis with synovitis, deformities, erosions, etc. He's been treated with a plethora of DMARDs and biologics in the past, and he says that the only drug that really worked for him and has worked for him has been etanercept. But the problem is that etanercept, not the strongest drug at controlling skin psoriasis, really good at joint psoriatic disease. His problematic skin required him to be on another DMARD. So combination regimen was the norm. Many years it was methotrexate plus etanercept. Sometimes we tried other things like leflunomide and cyclosporin. And later we graduated to secukinumab. On secukinumab, he developed really severe colitis. Ultimately diagnosed with ulcerative colitis. While it seems it was secukinumab induced, it was later felt because it persisted, years it persisted, and never went away and required ultimately more aggressive therapy. He's tried on multiple things, and it wasn't until he got to tofacitinib, 10 milligrams BID, the dose for ulcerative colitis, that he had great control of the ulcerative colitis. While he's doing that, he's also taking etanercept. At times, weekly, but for the most part, every 3 weeks or so. The question is this legit? Can you get away with this? Should this be allowed? I'll remind you that, first off, Xeljanz or tofacitinib is a DMARD. It's not a biologic. So this is not combination biologic. This is combination therapy with a DMARD and a biologic, and that works. We know that works. This is combination expensive therapies that makes everybody nervous. So what about combination biologics? Can you do that? There's lots of animal models that showing that you can inhibit multiple arms of the immune system with great additive benefit. So they are at least additive, sometimes synergistic. So in animal models, it is clearly safe and beneficial. There is a sort of FDA stance on the package inserts of TNF inhibitors and IL-1 inhibitors that biologics shouldn't be combined. And that's because there were studies done early on where IL-1 inhibitors were combined with TNF inhibitors. And while it didn't show an additive clinical benefit, it did show added infectious risk. So from any one drug, the SIE risk was like 2%, but being on both of them gave you an SIE risk of 6%, which is higher, but it's not like life-threatening dangerous either. So again, should we be outlawing combination biologics if it wasn't for the money? So in this man, he is doing great on tofacitinib and barely taking a little bit of etanercept. How does he get it approved? Well, his insurance actually does approve it or does pay for it. There are other combinations that are commonly in use out there right now for which there's little evidence, but there are major concerns about the cost of such combinations. But when they don't want to talk about cost because it's uncomfortable, they say, well, what about the safety? Well, you're really talking about cost, isn't it? Isn't that what you're really talking about? So a Primilast and a TNF inhibitor. A lot of people are doing that. Or a Primilast plus an IL-17 inhibitor. What about JAKs, the DMARD, being combined with TNF inhibitors? What about IL-1 inhibitors being combined with other biologics, like, as we said, TNF inhibitors? So who should pay for it? If you have very liberal insurance, they'll pay for it. Sometimes patients pay out of pocket for the drug that their insurance is not going to pay for, or they have stockpiled a bunch of it to pay for it for a while, or sometimes you help them out by giving them samples. I think sometimes you're going to have to go to appeal to the payer to talk about this. I have had success taking the tact that I'm treating two different diseases that do not have overlapping biologies, and hence there's not one drug that's going to treat both diseases. That is in play here. This man has psoriatic arthritis and psoriasis. They really don't respond the same to all of our drugs. I've often applied this to patients who have autoinflammatory conditions and man-eating seronegative but erosive RA. So I call this RA plus Still's disease or whatever. You can also say this for IBD plus another condition like rheumatoid arthritis or psoriatic disease. That's the tack that should allow for the funding of 2 biologics. Of course, you do take the added risk of a potentiation of an infectious risk, but there doesn't seem to be any other risk when you add in biologics. But recognize that the added infectious risk is already in play. People with severe enough disease that you want to use 2 biologics are already going to have a much higher risk of serious infectious events. The question is, are you adding to it significantly? It's possible, and hence this is a risk-benefit discussion between you and the patient. That's it for QD Clinics. Tune in next week for more great cases.